Okay, pulmonary edema. All right, pulmonary edema is a true medical emergency that occurs when the pressure within the lungs becomes so increased that fluid moves from the intervascular space into your alveoli, your bronchi, and your bronchioles. If not treated rather quickly, pulmonary edema can cause death. So, in essence, it's an exacerbated version of left heart failure. That pressure is too much in the lungs, and it's now forcing out of the pulmonary capillaries and into the alveolar spaces. It can result from left ventricular failure. When left ventricular failure occurs, remember that blood backs up in the pulmonary circulation, and that can cause pulmonary edema. MI can also be a cause of pulmonary edema. Like I said, heart failure and valvular disease can also be a cause of pulmonary edema. Also, rapid administrations of IV fluids can also cause acute pulmonary edema. Risk factors for pulmonary edema are the same as heart failure. If you hear, I think you've heard me talk about flash pulmonary edema, and flash pulmonary edema is when it comes on very suddenly, very acutely. Non-cardiac pulmonary edema is a lung disorder, and its causes are usually due to a secondary issue, like acute respiratory distress, sepsis, trauma, IV fluid overload, drug overdose. Cardiac pulmonary edema is a sign that there is a cardiac decompensation. So what does that mean? That means that the heart is failing. How do you know that your patient has pulmonary edema? Shortness of breath, difficulty breathing, feeling like they're drowning, or that they have a need for air, they have that air hunger sensation, cyanosis, gurgling sounds with breathing, wheezing, crackles, orthopnea, tachycardia, pink frothy sputum, cardinal sign and symptom of pulmonary edema, anxiety, restlessness, cool clammy skin. What are you going to feel, or what are you going to hear as far as how heart sounds when you have a patient with pulmonary edema? Hopefully you're saying that you're going to hear an S3 because your patient has overload, and that S3, remember, comes immediately after the S2. Right? How do we help our patients with pulmonary edema? So, treatment options. If they are truly in respiratory distress as a result of pulmonary edema, we're going to assist with intubation. If they're not intubated, chances are they will require a high amount of oxygen, maybe 40 to 60%. Patient needs to be in a semi-Fowler's position or dangling on the side of the bed to help ease shortness of breath. If your patient sits up with their legs dangling, it actually reduces venous return by trapping fluid in the extremities, which can help their shortness of breath. Morphine can help reduce anxiety. It's a vasodilator, so it reduces venous return. Oxygen with positive pressure, so your CPAP, your BiPAP, your ventilation. We're going to give a diuretic like furosemide. Remember that when you are thinking about a patient with pulmonary edema, you are recognizing that this is absolutely a medical emergency, and this is where you have to go. Airway, breathing, circulation. These patients feel like they are literally drowning. Once your patient has stabilized, you can then move on to try and find the cause of pulmonary edema and take it from that aspect. These next couple of slides talk about valvular heart disease, generally speaking, and then we'll break it down and talk about the individual inflammatory diseases of the heart. So inflammatory diseases of the heart are really defined as inflammation of any layer of cardiac tissue. So whether that's the endocardium, the myocardium, or the pericardium, and that can damage valves, muscles, or pericardial lining. So underneath that umbrella definition includes rheumatic heart disease, endocarditis, myocarditis, and pericarditis. We will talk about all those individually here in just a little bit. Rheumatic heart disease is caused by a beta hemolytic strep bacteria. Endocarditis is usually caused by a bacterial infection or an abnormal immune reaction. Myocarditis can be bacterial, viral, or fungal. Pericarditis, cardiac trauma, myocardial infarction, infection, or rheumatic fever. Lots of things can damage heart valves. Like I said, endocarditis, rheumatic heart disease, myocardial infarction, congenital defects, aging. There's two major types of disorders that we'll talk about here in just a couple of slides. Stenosis and regurgitation. When you hear about mitral stenosis or mitral regurgitation. Scarring of the valves that lead to scarring of the valves leads to stenosis. That stenosis makes those valve leaves fuse together and they cannot open properly. Valves that do not close completely are also called insufficient or incompetent because they allow that backflow of blood. If valves don't function correctly, they will interfere with how blood flows smoothly through the heart. That turbulent flow, or backflow, can cause a murmur. We typically don't see as much valvular disease in the tricuspid and pulmonic valves as we do in mitral and aortic because the pressures are greater in the left side of the heart. Okay, just a review of the valves: mitral, aortic, tricuspid, and pulmonic. When you hear somebody say that they have mitral valve prolapse, it means that the valve flops into the ventricle during systole, usually a benign issue. Although a patient with mitral valve prolapse is at increased risk for bacterial endocarditis. If a patient has mitral valve prolapse, they can have atypical chest pain as their most common symptom. Mitral stenosis is narrowing of the valve, can be caused by rheumatic heart disease or bacterial endocarditis. Rheumatic heart disease is the usual cause of mitral regurgitation. How do we figure out that we have a valve issue? Upon assessment, you're going to hear a heart murmur. Patients may have an echo or a cardiac cath, but the best way to visualize issues with heart valves is through a TEE, which is what we talked about earlier. Okay, patients with valvular diseases in general need to be on anticoagulants, especially if you have a mechanical valve, which I think is on the next slide. A balloon valvuloplasty is like a coronary angioplasty. The balloon is placed through the valve and inflated to divide the fused leaflets. Surgery to repair is typically the choice. It's less risk than replacing the entire valve. So the different types of valve replacements: mechanical versus biological. Biological valve replacements are less durable than mechanical, but with biological replacements, you do not need anticoagulants because the blood flow is more normal, easier to treat infections. Mechanical valve has long-term durability, but you do have to be on lifetime anticoagulants. How do we prevent heart valve disorders? Specifically, we try and especially prevent rheumatic heart disease. This is a picture of mitral valve vegetation shown here in an echocardiogram. You can kind of see there if you look at the arrow. We'll talk more specifically now about rheumatic heart disease, endocarditis, pericarditis, and everything. Rheumatic heart disease is a valvular deformity which slowly progresses, usually follows an acute or repeated episode of rheumatic fever that's again caused from a beta hemolytic strep bacteria. What happens in rheumatic heart disease, the pathophys behind it, your valves become red, swollen, and inflamed, and lesions develop on the leaflets. Over time, scar tissue develops, leaflets become rigid and deformed, leading to stenosis or regurgitation. Typically, your mitral valve is affected most often. When you talk about when you talk about signs and symptoms of rheumatic heart disease, because rheumatic heart disease begins usually with a strep infection, begins with strep throat from a strep infection, you always want to assess your patient to see if they've had a recent strep infection. When strep goes untreated, it can lead to rheumatic heart fever. And again, rheumatic heart fever is the most common cause of valvular disease. When you have a patient who has rheumatic heart disease, you are going to see fever, polyarthritis, carditis, a pericardial friction rub, a murmur possibly, cardiomegaly, possibly a pericardial effusion. So if you look here at this picture on the visual, you can see that patients who have acute rheumatic fever, they also, in addition to having fever, they have the polyarthritis. So these patients have swollen joint nodules, and it can be extremely painful for patients. Phases of the disease, we kind of talked about this. Patient has an acute episode of strep. They recover. They could even be symptom-free for 1 to 5 weeks, and then they can start seeing signs and symptoms of rheumatic heart disease. It can be seen between ages 5 and 15, but usually seen between ages 5 and 15, but can be seen at any age. Only 10% of those with rheumatic fever develop rheumatic heart disease, which again is progressive damage to the heart valve, resulting in stenosis of the valves or regurgitation. And again, your mitral valve is the valve that's most commonly affected. Like I said in the last slide, more signs and symptoms here. Red swollen joints, subcutaneous nodules. We talked about the cardiac symptoms. You develop these thickened red synovial membranes around the joints, which is very painful. You can also develop petechiae. Pain usually affects the large joints like your knees, hips, and elbows. The nodules that we're talking about, usually in your wrist, elbow, and ankle. Heart murmurs. You may see neurological symptoms, including irritability, behavior changes, or involuntary movements. So, again, how do you know your patient has it? Did they have a recent strep infection? You're looking for their ASO titer. An ASO titer is a test for strep antibodies. It rises within 2 months of onset. You're also looking for the C-reactive protein to be present. That's positive for an active inflammatory process within the body. EKG irregularities, you're going to see a prolonged PR interval, and on an echo, you would actually see the valvular damage. Carditis can develop in 50% of inflammation of the heart, and that inflammatory process usually involves all 3 layers of the heart. Medical management: increase fluids, monitor vital signs, antibiotics, analgesics, and corticosteroids. Penicillin is the drug of choice for 10 days. If allergic to penicillin, you're going to use erythromycin, ERYTHROMYCIN, or clindamycin. For pain and discomfort, aspirin. No NSAIDs, not effective. Corticosteroids for severe inflammation. If you're an athlete, limit athletic activity for 6 months. Rheumatic fever is absolutely 100% preventable. Identify and treat strep appropriately. Signs and symptoms of strep: swelling, typical lymph node. When a patient has strep, you want to make sure you tell them to finish all of their medication for the strep, even if they're feeling We're almost to the end, I promise. I know you guys are tired of hearing me talk. Endocarditis is the inflammation of the lining of the heart and involves any part of the endothelial lining of the heart. Most often, the mitral valve is affected. Staph is a typical infective organism when we're talking about endocarditis. Begins with vegetation on healthy valves and on damaged valves or endocardial tissue. Greatest risk factor for endocarditis is previous heart damage, like an artificial valve, can be from IV drug use, oral lesions, dental procedures, IV catheter insertions, a urinary catheter infection, body piercings, and in subacute endocarditis, lesions develop on previously damaged valves. With endocarditis, you can treat endocarditis is composed of platelets, bacteria, and a protein involved. If you don't treat endocarditis, it can to see for sure what's growing. Echo to see vegetation on valves and to evaluate valve function. Positive sorry. vegetation that may embolize, remove the valve if it's continuing to be the source of infection. Okay, once the organism is identified, antibiotic therapy is structured to treat that organism. Usually takes weeks to treat the patient. Prevention of high-risk patients is of highest importance. Prescribe antibiotics for patients with pre-existing valve disease or heart problems prior to any high-risk procedures, such as dental procedures, most surgeries, anything involving a scope like an endoscopy, catheterization, INDs, even vaginal deliveries. Extended courses of IV antibiotics may be needed. And we need to know what's growing to make sure that the antibiotics are most effective. All right. Pericarditis. Pericarditis is inflammation of the outer layer of the heart. Can be primary or secondary due to other disease processes. It is a frequent complication of end-stage renal failure, frequently seen also after myocardial infarctions or after cardiac surgeries. So it can be, again, acute. It is typically viral. If it's going to occur postoperatively, it can occur 10 days to 2 months postoperatively. Other common causes, we talked about those, MI, cardiac surgery, end-stage renal disease. So what is actually happening in pericarditis? I'm sorry, you guys. When inflammatory mediators are released, there's vasodilation that causes increased blood flow and edema. Increased capillary permeability allows plasma proteins and fibrinogen to gather in that pericardial space. You have exudate that is formed that may cause, or that may already have bacteria in it or be purulent if infected. You can then have additional fibrosis and scarring that may restrict the heart's ability to function effectively. You can develop pericardial effusions. Chest pain also will occur due to the inflammation there. Acute pericarditis can last from 2 to 6 weeks. Signs and symptoms include chest pain, pericardial friction rub, fever, decreased cardiac output. Remember, a pericardial friction rub is like that creaking sound, walking on a wooden floor, like a grating sound. Just a picture of the pericardium, remember, is the thin sac enclosing the heart. Here's a picture of a pericardial effusion where that pericardial space is filled with fluid and is pushing against the heart. Okay. Treatment for pericarditis includes diuretics. If you have a pericardial effusion, you're going to have a pericardiocentesis if that fluid is present. You're always going to be reassessing your cardiovascular status, your renal status, and your respiratory status. The issue with pericarditis is that it is viral. So there's not a whole lot we can do as far as medications to treat the actual pericarditis. All right, real quick back to this page where it showed you the picture of the pericardial effusion, which is that abnormal collection of fluid there in that pericardial space. Remember how we talked about patients who need a thoracentesis and have a pleural effusion? Same concept here. So that pericardial effusion can develop as a gradual process and that space can actually accommodate up to 2 liters. The problem is when fluid or blood accumulates in that space rapidly, because then the sac of the heart cannot stretch. The heart becomes compressed, your ventricles are not filling and contracting like they should. This is referred to as cardiac tamponade, which is absolutely life-threatening. We have to get that fluid out of there or that blood out of that space, and the treatment is a pericardiocentesis. Okay, so Again, I've gone a little bit, talked more than I wanted to on this podcast. The only thing left in this, in these slides here is pacemakers, and I think I'll combine pacemakers when we do EKG rhythms. So hang tight on that information, okay?